Now we see.
When I was a kid, I used to watch these movies, and you see the natives like scream. Testing. Okay.
Oh, yeah, you have to, did you know where you were? Did you find this place? Because I was searching all over. Is that you? Is that you? Oh, well, that's one way to tell. Okay. But you're not sure if you want to sit.
Well, you notice all the seats around you are empty. Everybody else is sitting together. All the seats around you are empty, and all the rest is sitting together. This we're just testing for the paranoia scale. I'm not thinking. So.
Isn't that nice of you to open that up?
It'll pick me up, okay. So we're gonna get started. Just one change. On your agenda, following Jacob's presentation, is like a Q&A session that says management team. That was meant to be clinical Q&A for this group, which we will do. And if you do have specific questions more for the management team on the business side, we want to table that till tomorrow. So just let us know that we need to go ahead and do that. But right now, we just want to focus on the clinical. And then once the Q&A is done, depending, you're going to go to ITC. You may, if we get done a little early, then you just have a little longer break between going over there. Okay. Great. Jacob?
Thanks. So we'll go ahead, and what I'd like to talk about today will be kind of shifting perspective a bit. It's just like when Scott was talking about, it's all how you frame it, how you look at it to a good degree. We can look at CFS coming from many perspectives, and I'd like to kind of focus it on the autonomic dysfunction, the cardiac function, and the implications of that, and talk about some of the new research associated with autonomic dysfunction and cardiac dysfunction in CFS and fibromyalgia. Also, you're going to have patients that are coming in that are going to say, well, I heard this and I've heard that, and what do you think about this and that? And when you can go and go, oh yes, well this is, and talk about it, they walk out going, God, my doctor's great, they know all this stuff. As opposed to when they go to most of the doctors and the doctor goes, fibromyalgia? It's like, so. Okay. So I want to bring up today also some of the newer things that are in the news and put those in perspective. Now again, we've talked in the past about CFS and fibromyalgia representing an energy crisis. And this still is, the case. The production of energy results in hypothalamic dysfunction. The area that uses the most energy for its size goes offline. This is all stuff we've talked about over and over and over. In addition, muscles use a lot of energy. They malfunction. They get stuck in the shortened position. People get chronic pain. But it's important to remember that the heart is also a muscle. And just like people have tender points and you can feel the muscle dysfunction, they complain of the pain, these patients also are going to have cardiac dysfunction. So we want to look at that. So when you talk about the hypothalamic dysfunction, we talk about it controlling sleep, hormonal function, temperature regulation, and autonomic function. And we don't talk that much about the dysautonomia, and that's why I wanted to update that today. But another effect of the hypothalamic dysfunction is these people are chronically dehydrated. And some of you, if you watch all the pitchers of water around the table this morning, you'll notice most of the pitchers were unused and mine was gone. I didn't leave any for Lauren and I didn't leave any for the other folks. So Jill was very gracious when I went after the pitchers and keep swatting my hand. But that's still my holdover from 1975 when I had chronic fatigue syndrome. I still have the drink like a fish, pee like a racehorse kind of a thing. Why do we have that hypovolemia in this disease? Well, again, the hypothalamus regulates production of antidiuretic hormone, or vasopressin. Also, with the hypothalamic pituitary axis being down, you're going to see low adrenal function. So again, this drink like a fish, pee like a racehorse is part of standard part of CFS and results in dehydration. So in addition to these other things that are going on, I want to look at the dysautonomia and the hypovolemia and the effect that that has on this illness.
And Jacob, whenever I'm asking them in the questionnaire and I says, do you urinate a lot at night? And they'll say, yes, but I drink a lot of water.
Mm-hmm.
And they all justify the reason that they just drink a lot of water.
Right.
Not understanding that's part of the dysfunction.
But see, what they need to know is that a lot of people are afraid that if they drink the water, that pushes their peeing, so they try to dehydrate themselves and stop the drinking. Now, around bedtime, that makes sense, because you don't want them up all night peeing. And interestingly, we're going to talk about DDAVP not being effective. That's vasopressin. You can do it by no spare tablets. But for the peeing at night, for those who can't sleep because they're up all night peeing, it is helpful in that population. So they need to know that they're not peeing because they're drinking a lot. They're drinking a lot because they're going to be peeing a lot no matter what, whether they drink a lot or not. And if they try to drink less so they don't pee as much, they will dehydrate themselves and make themselves sicker. So better to pee a lot, better to chase it. It's the peeing that comes first. The increased volume intake is secondary. And but people get that. They see that connection going on. Now, in addition to the autonomic dysfunction, the energy crisis causes poor muscle function, so you're going to see cardiac dysfunction. Question mark, there may be a stiff ventricle, which means that the heart muscle can't relax enough. Muscles, when they get stuck and they don't have energy, get stuck in the shortened position. So the ventricle and the atrium may not fill enough, may not relax enough to fill properly. So you're going to decrease cardiac function. Now that I put question mark there because the data goes back and forth with it. But what is pretty clear is that there's decreased cardiac function as part of the disease. Small heart syndrome, where the heart size is smaller than most people, has been noted in a number of studies in CFS. And people are going to come in having read, oh my God, here I'm sick, is my heart failing, doctor? And you tell them, nope, it's just a muscle like the rest of it. There's no damage to the heart, and it recovers just fine when you treat the whole thing. The main thing they need is reassurance, but we're going to gear treatment as well. So, as you look at the hypothalamic dysfunction, we talk about this being an energy crisis. People don't have enough energy to keep up with the function, but there's also a lot of issues in terms of toxins. Toxins can directly suppress the hypothalamus, and Dr. Shoemaker's work, his theory is that the toxins suppress MSH and other hypothalamic neurotransmitters. So low energy toxins can also be an issue. I want to bring up head injury because many, if not most of you, have had patients that come in, and if you look at the questionnaire, there's been a history of head trauma. And the majority of people who have head injury that's significant will have hypothalamic pituitary dysfunction down the line from it. And it's missed most of the time. Now, if you look at the JAMA meta-analysis, you're looking at 27.5%. But these folks, if you're looking at these studies, people have to be in the lowest, below 2 standard deviations by and large, before they're considered abnormal. It's kind of like if they said, do injuries cause loss of income? And you had to be below poverty levels, before it would actually count it. If you went from 100,000 a year to 15,000, you would not be part of that 27% till you dropped under the 15,000 a year or so. So you'll see the majority of people will get hypopituitary, decreased pituitary function after traumatic brain injury. And in fact, there's this one that I sent over last week. Is Debbie up there? That she's going to be seeing you in Colorado. She's sending her daughter who had traumatic brain injury, and the doctors, of course, said, everything's fine. Well, she's near, like that. And you've got to tune up the hormonal function. Presume, if there's a history of head trauma preceding the onset of the disease, presume that it's causing hypopit. and just treat the hormonal issues aggressively. The testing will miss it. If you're doing the TRH and the other stimulation testing, like I said, unless you're prepared to be considered that your shoe size is fine unless it goes under 4. Your income is fine unless it goes under 15. These are 1,000 a year. These are the normal ranges. Normal ranges don't mean squat. So again, other causes of the hypothalamic pituitary axis dysfunction. So just coming down, we're kind of taking the chain and looking at the dysautonomia part of it. And you can look at CFS from many different angles. And there's some who look at it totally from the perspective of it being a dysautonomia. The autonomic system is so pervasive, affects so much in the way body functions, that you can kind of look at most everything. And in a sense, you can frame it that this is dysautonomia associated with the hypothalamic dysfunction. Some of the main tests that are used to kind of determine autonomic function, and these are more in research settings. Some doctors will use them. Naturopaths are more likely to be using the heart rate variability testing than a lot of the MDs. I think we're still kind of early in the process, and I'm not as impressed with it. I think it's just a way to make a lot of money and to, you can say, do you fall down and does your heart rate zip up every time you stand up? You can put a machine that goes beep, beep, beep on it. I would not bother with it. But in the studies, they've looked at it. They'll use equipment that's probably a little more durable and reliable. But heart rate variability is one of the things they looked at. What people with CFS by and large show with the autonomic dysfunction is that these patients are in sympathetic overdrive. Put differently, this is a disease of adrenaline junkies, or people whose adrenaline systems have been overstimulated, and then it exhausts. And now they actually have a decreased response. If you do a stressor response, they respond less aggressively than most do. One way to think about it is if you had CFS patients and early in the disease, you walked up behind them, you tapped them on the shoulder and you went, boo. They jump about a foot higher than most people. But as the disease progresses, they don't jump at all. They've kind of exhausted their startle reflex. They've exhausted their sympathetic overdrive. Another way that's used to look for dysautonomia is a questionnaire called the COMPASS questionnaire. And this can also be used to screen for autonomic dysfunction, mostly in research studies. I don't recommend using it in practice because we know this is present in this population. We're looking for the same symptoms, but we're just asking them in different ways in our questionnaire. But if you want to hunt down the COMPASS questionnaire, you probably can. It's going to be one more piece of paper. But that's one of the ways they look at it, just get a sense of, well, how do they tell if it's there? Other ways, certainly looking tilt table testing, which is a good way to make the patients miserable because first they feel sick as a dog when they're on the tilt table, and then when the insurance company says that it's not covered and they get a bill for $1,500, they get even sicker. So again, it's something that I would just empirically look for if they have the symptoms, and we'll talk about that, just kind of treat it. But what are the symptoms of dysautonomia? What makes you think of autonomic dysfunction in this population? So you have many of them. One of the more common ones, orthostatic symptoms. These people, when they stand up, will often get dizzy. They'll have lightheadedness, they'll have blood pressure will drop. With exercise, most people will find that their pulse goes up with exercise, and these folks will go up, but often drops. Vasomotor, sweating, weird sweating. Sweat in the back of my neck or sweat in the back of one leg. People will get these weird sweating patterns. Dry eyes, dry mouth, GI symptoms. Peristalsis. What makes it that when you ate lunch today, it started this way and keeps going all the way down the other end, as opposed to like going down and up, down, down, back up, sitting there. That's controlled by autonomic function. That's vagal control largely. And you're going to see a lot of people have GI symptoms, diarrhea, constipation, be part of it. Now again, a lot of that is bowel infections. We'll talk about that in a bit. But part of this is, again, the lack of peristalsis. Some of you may even have people who basically have lost most of their motility. And they have gastroparesis. Anybody here dealing with folks with gastroparesis? You'll see that some folks have had their colon removed. The doctors, which I look at that, and makes me go, my God, you know. But I've seen, there was one who sent me a picture of her colon actually hanging on a wall. It was like, I don't know how she got it from pathology, and it was like, oh.
Right where it belongs, yeah.
But it's insane. I mean, you know, what you'll see that people will go through. I was giving a lecture the other day. It was on a web lecture that we had over about 100 folks, and we did Q&A after. And one of the questions was, one of the patients had gastroparesis. And the doctors basically said, well, there's nothing we can do for you. You know, don't eat. She was eating multiple meals a day. They said, well, just eat 3 meals a day. I said, that's one way to make you sick as a dog real quick in this disease. So how do you treat the gastroparesis? Well, one, you treat the autonomic function with shine. But I'm going to give you another little trick. In addition to the magnesium and the fiber and the rest, a couple tricks we'll talk about. One, Dexedrine has been shown to be helpful for gastroparesis. Dexedrine is wonderful for dysautonomia in general. I don't know why. Could be that the dopamine, I can speculate. We'll talk about the tyrosine being low in a moment. Dopamine and adrenaline come from tyrosine. So perhaps raising dopamine is part of the issue, which the Dexedrine and Ritalin will do. Chewing gum also stimulates peristalsis. Just make it sugar-free gum. Studies have shown that people get out of the hospital after surgery where they basically have loss of bowel sounds. If they just simply chew gum afterwards, it stimulates peristalsis.
Typically, which doses of Dex is helpful?
I would not go over 15 milligrams for most adults or over 30 for most children. It's an odd thing, but children need and tolerate higher doses than adults do.
Per day or per dose?
Per day. And most of it in the morning. They have sustained release forms, so you can give it most in the morning and some in the afternoon. We'll talk about that as we go through. I'll have that a bit more.
Sugar-free gum is dental issues?
Sugar-free gum is one. The sugar is toxic in this disease. My upcoming book coming out in spring will be Beat Sugar Addiction Now. 2, you're going to rot their teeth. These people have dry mouth already.
So xylitol is okay?
Yeah, xylitol actually is anti-carcinogenic. Any of the sugar alcohols, OLs, are fine. But you'll find these people often say, well, I suddenly had 18 cavities this year. Well, one, they have dry eyes, dry mouth, you know, secretomotor. These patients have Sicca syndrome, the majority. And saliva is what prevents cavities. That's one of the biggest ways of prevention. And then what do we do? Oh, have some Elavil. Oh, no! You know, you're taking a bad dry mouth situation and you're making it horrendous. And these people literally, how many of you had people come and say, I had this flurry of a half a dozen cavities or more? This is a dry mouth compounded by the medications that are drying. So be conscious of that. Everything, oh, it's a minor thing, dry mouth. Not when they start looking at you, you know, and want to pull out all your teeth and put in, you know, root canals or dentures from this. Dry mouth, major issue in this disease, part of the autonomic dysfunction. There's also an autoimmune component to it as well. But diarrhea, constipation, other symptoms that the Compass scale looks at, bladder symptoms. It's part of that drink like a fish, pee like a racehorse thing. But part of that is bladder spasm. Magnesium will help that. Nighttime, as you mentioned, the DDAVP for those with really problematic nocturia will be helpful. But I'll give you another little trick too. There's a trigger point where the abdominal rectus muscle attaches to the pubic bone. And you can feel that bone right at the top of the pelvis. And if you push on top of that bone, you'll find many people, the insertion sites of that muscle are very tender. And you could even put some Lidoderm over that, or hot compress. When you relax those insertion sites, there's a reflex loop between those insertion sites and the bladder that triggers spasticity. On the other end of the muscle, in this upside down V in the sternal notch, or in the, in the solar plexus, not sternal notch, but you'll see that there's a tenderness at the bottom of these muscles in a lot of people who have acid reflux and indigestion. And when you turn off those muscles, you can just use a cold spray. We used to use fluoromethane. back in Janet Travell's days. You can block it in seconds, and their indigestion pain goes away. So there's a reflex arc between reflux, which is dysautonomia, but there's more going on. So we're going to talk about the dysautonomia, which is a major cause of the acid reflux, because again, it controls peristalsis. When that function is off, things are going to be going all kind of directions, and not at all. And the bladder, you see the same thing.
I was just going to say there's some very effective osteopathic manipulative techniques for those areas you're talking about that look extremely well, strain, kind of strain. You just talked about two diagnostic points. So if you
Yes.
got somebody that knows how to do that, that will work very well too.
It can be very helpful. For the muscle pain too, there's a very nice osteopathic manipulation where you have a lot of people have chest pain, and it freaks the hell out of them. And every time they get chest pain, they think they're going to die. And what do? They tighten up their muscles right away because they think they're going to die. So you can reproduce it by pushing on it, and then you talk about the ribs are this thick. And if it was coming from beneath the ribs, pushing on it would not reproduce it. And that's something they get on an emotional level. It's like, aha. But then there's a nice little manipulation then, is you simply hold down and then you have them breathe. Well, you're keeping that rib in place because you're holding it down. Your force is not going inward, it's going towards the feet. And then they're breathing, it's a passive stretching, and then you move up one rib at a time, and you'll release those muscles as well. There's an awful lot in osteopathic manipulation and in chiropractic manipulation, which of course as physicians we're not taught about it, so it's stupid. Everybody is crazy and stupid but us. Anyway, but as Boyd is noting, and that's not correct. We have one little piece of the puzzle. So keep your eyes and ears open for the other pieces and start working together. And I'm going to say again, do cross-referral patterns within your community. You know, with people who do manipulation, people who do, nutrition, the things that you're not good at. Have lunch with the people that are. Ask around, find out who's good, and set up cross-referrals because they want to have somebody they can send to prescribe, who is not going to say that they're crazy and steal their patients. Find the good people. Create your own cross-referral patterns. But thank you. Yeah, the manipulations make a big, big difference here.
It's a piece.
Piece. So bladder, pupillar motor, sleep, part of the sleep dysfunction, dysautonomia. If you're constantly putting out sympathetic adrenaline overdrive, when your body is supposed to be shifting into parasympathetic mode, you're going to get alpha wave intrusion into delta sleep. You're going to have disrupted sleep. The other thing you're going to get is hypoglycemic. And they wake up 2 to 4 in the middle of the night, in part because their blood sugar is dropping, because their cortisol is low and they're having their sympathetic stimulation. And syncope. Some of these patients even pass out. Most just get dizzy. But these are the symptoms looked at on the Compass scale, looking for dysautonomia.
Jacob, is tachycardia part of it?
Yeah, postural orthostatic tachycardia syndrome, but it's both tachy and Brady. Because of sympathetic overdrive, you will have more of the racing heart, but what you get then is this reflex where it drops it down too low. The patients will note when their heart is racing, because they'll feel this like flutter or racing heart, but when it goes low, all they notice is that I feel like I gotta lay down. So you'll see both, but you can see it more on the fast side. So if you look at this whole combination of symptoms to look for autonomic dysfunction in the Compass scale, and that's called the Composite Autonomic Symptom Scale. And this was a study, a very nice little study actually. The fibromyalgia group scored 55 versus 10 for the control group. So again, a lot of these symptoms going on. They used, it's funny, they like to use rheumatoid arthritis as a control group against fibro for a lot, I don't know why. I guess they figure it's widespread pain, it's immune, it's mostly women, blah, 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 blah. But so that was 21 for that group. But what they may not have looked at, again, a lot of people with rheumatoid arthritis have a secondary fibromyalgia. So, you can come on if you need. So if you take a look at dysautonomia, again, the overriding theory is of sympathetic overactivity. Okay. Somebody's getting the call over there. That's it. So you're getting sympathetic adrenaline overdrive. What are other things that show this? One, you have decreased levels of tyrosine. This is the amino acid tyrosine, makes dopamine, which goes to epinephrine and norepinephrine. So if you're constantly stimulating adrenaline, you're going to use up the tyrosine. You're also going to start to develop dopamine deficiency and excesses of norepinephrine at the end of the day. So there's research. This is a nice study done looking at amino acid homeostasis in fibromyalgia in 2009 in March. The study authors concluded that given the reduced tyrosine ratio in fibromyalgia patients, a possible impairment of the adrenaline system in fibromyalgia may be suggested. So you're seeing a number of things that are pointing to these people are adrenaline overdrive junkies.
Is that a blood test we should check?
I think, I'm trying to remember. I think it was probably blood testing. I'd have to look that up again. I think so, but I'm not sure. But I can double check that for you. I doubt that it'll be urine testing because it's hard to make the claim from urine because you may just be excessive losses versus arrest. So I think that there was on blood analysis, but I'm not sure, so I don't want to say for sure. Now, so we've looked at some of the basis for the dysautonomia. Now, how about cardiac dysfunction? You know, why are we saying that there's cardiac dysfunction going on here? One, as I mentioned, several studies have shown the small heart is common in CFS. If you look at the chest X-ray, the cardiac silhouette relative to the entire chest is smaller. Study we talked about, there's numerous studies, actually several, showing that cardiac volume is lower. In fact, it's down by 10% in severe CFS versus healthy controls. Cardiac contractility decreased by 25% in severe CFS. Think about that. Normal ejection fraction is, say, 55%. And they didn't look at the EF, but just in terms that many of us are more used to, you drop that by 25%, you're looking at 30%. Heart transplant, not getting that far below that. So what we're seeing is a marked decrease in contractility in the heart. And as one would expect with an excess adrenaline, systemic vascular resistance is up. So you have faster heart rates in many. You've got less blood being pumped per. You've got low blood pressure. The periphery is trying to contract to keep the blood pressure up, getting cold feet, cold hands at the same time. So there is evidence for cardiac dysfunction. But there's a nice study. Nancy Klimas, one of my favorite researchers in the field. She and I don't always see eye to eye, but I always respect her. Neat lady down at the University of Miami. Hurwitz was the lead author. They looked at cardiac function relative to blood volume and red blood cell mass. And I think this is a critical study to be aware of. They found that 2/3 of patients with CFS were hypovolemic. They had low blood volume. Now, we talked about earlier the dysautonomia, adrenal function will contribute to the dehydration. But also, red blood cell mass is significantly lower in the CFS population. But what happens when you're doing a CBC and you're looking at the hematocrit? Now, say, if you have the tube of blood, and it was funny when I was on the Oz show yesterday with Mehmet, what he would do is he also talked about anemia as fatigue, and he actually showed a tube of blood, juggled it on the air a bit as he almost, it's little butterfingers a bit like me. And he showed, the tube of blood with the red blood spun down at the bottom and the plasma up at the top. Now, what happens if you decrease the red blood cell mass 20%? Well, you're going to be very anemic. But what happens if you also decrease the blood volume 20%? The hematocrit will be just the same and be normal. And that's what's going on in our population.
But the RBC mass would show up to be low at the top.
The RBC mass is 19% dropped. And this was, again, the study by Hurwitz. So what we found was the red blood cell mass, 19%. And the ones that were low, and those 2/3. Can you imagine bleeding out 19%? That's a lot. And then you add on top of that, they're 15% hypovolemic. They've lost 15% of their blood volume. Now, the saving grace I have is that this was a gradual adaptation. It's like the difference between somebody with renal failure who's going down to these low levels versus somebody who's bleeding out, who's going to be passed out on the floor. The body has had a chance to adapt. But think about it, losing 1/5 of our blood. Does a quick calculation say 45 hematocrit would be about 15 units of blood, I'm guessing. So that's like a 3-unit blood loss. My calculations may be off, but I think that's probably pretty close to what that would come out to. Yeah, imagine bleeding out don't even imagine it. Not a pretty picture, and somebody who's dehydrated. Mark?
So if we increase the volume, what will that do to the RBC mass?
It's going to unmask their anemia. The mass will stay the same, so it's going to be helpful. It will increase their cardiodynamic function, but you'll unmask the anemia on the CBC, on hematocrit. But take a look at those numbers. And those are the total blood volume deficit greater than 8% below ideal, which is 2/3 of the ones with severe CFS and 1/3 of those with moderate CFS in the study. And this was a really well done study. Nancy and her group, I mean, they're just, good white coat folks, great white coat, great heart, and really good mind. Mm-hmm. And Jill?
Replacing the volume to more normal unmask the anemia, right?
If you could do it and have it stick around.
I was going to say, how do you do that if they're...
We're going to talk about that whole thing. I'll try not, Bob, I know I'm driving you a little nuts back there with the camera. But again, I want you to look at those numbers. Those are not, can you imagine if I took about 15% off your height? Paycheck? I won't even go into clothes. Anyway, that's a different thing here. It's okay. But anyway, this is major. 20%, 19% drop in blood mass. So the interesting conclusion of the study, or one of the conclusions, they took a look and they kind of ran the numbers to see if the low blood volume and low red blood cell mass could account for the cardiac problems or whether there was an associated heart problem with it. What they found was that 91% of the cardiac changes that they saw in the study were caused by the hypovolemia and the low blood cell count. So what this says is that the heart problem is not primary. It's secondary to these other very treatable problems. Now, the other nice statement they made is that the elevated prevalence of the low blood cell volume suggests that in CFS, they have an anemia that goes undetected by standard blood testing. These patients are anemic despite normal labs. One more example. Don't treat the labs, treat the patient. But you can let the patient know these things. Yeah, the blood count's normal, but you're probably like somebody who's bled out 3 units in a severe case. Now, please do not run out and do a bunch of nuclear tagged blood cells scans, okay? Now, I do want to give the opposing view. Paul Cheney says, no, this is all cardiac. The whole thing's coming from the heart, that the heart is adapting to an anaerobic metabolism because of difficulty with metabolism causing elevated free radicals and damage, and therefore like a baby that's in utero or somebody who's a mountain climber where they're in an anaerobic low oxygen environment, the heart is doing that adaptation and actually getting a shunt, left-right shunt that's going on. And he does some interesting echocardiogram work, including injecting air bubbles and watching them bubble through and watching them shunt. These patients actually get a patent ductus that opens back up again. You'll see it going the other way. They go back almost to a neonatal kind of cardiodynamic. But what I will also note is that Paul, I think, has a very different patient population than anybody else in the whole world. God's social secretary, or whoever it is out there, seems to send him a select group of people. And we had our group of 25 in the Sonoma working group, and nobody else had patients like Paul's. We all mostly came away with great respect, realizing, don't know why you're getting those folks, but these aren't anything like our folks. And it's funny, he had a heart transplant. And, we tend to kind of focus on, it's an interesting thing. And I suspect the folks that he's getting very different, and a number of experts who see a lot of people with this disease. We've sat down and kind of discussed this over dinner and come to the same conclusion. Don't know why he's getting these people. Thank God he's getting them and not us, but they're not who we're seeing. So again, you'll see that people will read on the internet, well, what about Dr. Cheney who says it's all cardiac and blah, blah, blah? You say, well, it's a different population. It's not the ones with the severe pain. And it just, we find that the research is showing no. It's really these other things that are treatable. So again, I will emphasize, please do not go out and get an echocardiogram. You won't see these changes on the standard echo readings. You can look at the study and see what kind you need to do, but I would not bother with it. It will not change treatment one iota, but it will make your patient petrified as can be. And again, the blood volume testing, these are nice research tools in this setting. You don't need them clinically. But, mhm.
I'm sorry for interrupting.
No, please do.
Paul Cheney's work is from several years ago. Does he have anything more recent, or are we?
Oh, Paul is
referring
still
to-
doing this work right now. What he's focusing on now are bovine growth factors. He's taking buffaloes and taking their heart and taking growth factors. And what he does is he rubs a little bit of whatever he's going to use on the skin and checks the echo like 3 seconds later to see if it makes a difference.
But the study that you referred to, the cardiac function. and
This is new.
outputs- Oh, this is new?
Yeah.
Oh, okay.
If you look at the studies about 3 months ago,
Okay.
okay,
Oh.
May 26,
Oh, no,
2009.
This is not Paul's work.
Oh, Paul's hasn't been published that I've seen.
That's what I thought.
We would get together each year and compare research notes. And so this year we didn't have it, but the last couple of years we've had the 25 of us would just get together and just, compare notes. And so the question is, okay, that's all well and good.
I
Warner?
still don't get how Dr. Cheney, with this new testing method, decided that ribose and CoQ10 and vitamin C and
Because most of the things that seem to work, he puts it on the skin, and if he doesn't see immediate improvement, he doesn't recognize sometimes if you're stressing a piece of the system without treating the whole system. So instead of, what I say is you use things that have been shown in the research and clinically to help tens of thousands of people and see how they do and see if it's safe over the 30 years that you watch them. Or you can rub a little bit on the skin and see if you get a change on the test. Now, I don't know if you guys have figured me out enough to tell which way I lean to.
it seems like he changes his tune every so often.
Well, the thing is, his stuff goes back and forth, and Paul is brilliant. He's a really good man. I like him. But I find that let's just say, heartily disagree. And I'm the one who's saying, well, here's what we see clinically helping a lot of people. And he says, well, maybe it's dangerous. Well, I've been doing this 30 years. And if it ain't killed them yet, they've been functioning for 30 years, there's a pretty good chance it's not gonna. So he's doing it all pretty much based on the test. And also he has a new product coming out for the bovine, like I said, the buffalo growth factors. Yep. And again, I don't think his work is based on the money. I think he really is very heartfelt in what he's doing. But again, you can treat the test. So it's like treating a blood count. The hematocrit's fine. We don't have to do anything.
I question the validity of the testing that he's doing.
I don't. I just question the reproducibility of it. It's not been reproducible. Okay, let me put it in those terms. Okay, and it's all risky being here on tape. Hi, Paul. Sorry, but anyway, like I say, he's a very good man. But I think he has a very different subset. I think he gets a pure CFS, bedridden down to, we get more of the walking wounded, or 6 could be, but it's a different group. And we'll talk to other experts. I'm going to leave the names out of it just to keep the politics simpler. The same conclusion we find that. So, one, how do you treat the low blood volume then? Now again, you'll find that the IVs are very good. Saline, and that's why if you do a placebo-controlled study of saline versus the standard IVs or the Myers, you're going to see both of them are going to do much better. Because saline is not a placebo in this group. David Bell has done wonderful work looking at giving saline and the effect. You will get a quick, marked improvement. Now you're going to say, well, it's not sustainable. But if you have, it's part of getting people shifted towards balance again, and part of the healing process. So what I think that the IVs are a critical part of it, but you'll also find that any time somebody's having a flare, they have the severe stress and they're, oh my God, I'm back in bed again. Give them the saline IVs, give them the standard IVs. You're going to push them out of this imbalancing back onto a stable thing, and then they can tune them back up again. But increasing salt intake. So many people have this saying, oh, being good, we're supposed to avoid salt. Study after study after study has shown the higher the salt intake across the population, the longer their life and healthier the person. Now the exceptions, high blood pressure, heart failure. But outside of that, even the NHANES study, which is a study of over 10,000, it's the biggest nutritional survey. It's like the Framingham study for nutrition. Again, came out with a recent study showing higher salt intake associated with higher longevity. For those of you who get my newsletters, a recent one was 6 medical myths busted. One of them is salt is bad for you. Mark?
Jacob, one of the problems that we have is that women, as a general rule, are avoiding salt because
For the
of
puffy
fluid
fingers.
issues. They're afraid they'll gain weight. And the second one is that people have got so used to not eating salt. How do we get it back into their diet that they will do it?
One, you have them increase it to taste. You tell them salt is good for you, and as they start increasing it, their taste buds will get, less sensitized, and they'll be able to have more. In the middle of the hot Texas summers, I'm going to give them salt tablets if I need. So you want to push the salt intake. Now, again, because of the weight, they really feel puffy, fluid retention. You let them know that feeling of puffiness is not because they have too much water in their body or salt. It's because it's not staying in the blood vessels where it belongs, and it goes out into the tissue, so the rings get tight. And again, that's how you distinguish CHF from fluid retention. CHF, feet will be puffy, rings won't be, unless they're like near dead from it. So you tell them that's low thyroid and B6 deficiency. So we're going to give you the salt, but we're going to keep it in your blood vessel where it belongs, and then you won't have that. So again, increase salt intake, increase water intake. You need to do the two together. And just have them carry a good, water around with them wherever they are, and just don't have them count glasses of water a day. If you do, I want you to spend the rest of your life counting glasses of water a day. It'll get old real quick. How do they tell if they need water? Tell them every so often, check their mouth and lips. If they're thirsty, if they're dry, they're dehydrated. They need more water. So again, it's not glamorous, but it's critical. Push salt and water intake to restore blood volume. Optimize adrenal function. And the adrenal function is glucocorticoid, but also mineralocorticoid. It's what holds on to water. The saline IVs, and again, you will find the standard IVs. Those of you who use more of them will get better outcomes. I can't say enough good things about them. That's the nice thing about the new program where it's kind of a fixed price. So we won't have to keep people crippled to try to save money and leave them disabled so they can't work to save the money from the IVs. Use them. They make a major difference. And then adrenal support. Whether you're using the cortisone. You guys are going to go over to ICC this afternoon. You're going to see where the stuff is made. You have the sustained release. You have the other adrenal glandulars, licorice. You have adrenal product. Give the adrenal support. You will find when you do this, the low blood volume comes up. Now, if you only did that, then you would drive them anemic on the blood test. They'd come in feeling better, but their blood test would look worse. The doctor would say, what are you doing to make them anemic? There are other doctors on the outside who are wondering why you can get them well and we can't. So at the same time, you also want to increase red blood cell mass. That is easy to do. How do you increase red blood cell mass? Number one, optimize iron. And we forget about iron. We've talked over and over, you want to keep the ferritin, we have over 40, and I'm moving that up to over 50. Why? In the last year, we have studies coming out showing that in ferritins under 50, if you give iron, it decreases restless leg syndrome. It's more effective than the medication out there now for RLS. And RLS is not a Requip deficiency. And in fact, there's virtually almost no use in my practice anyway for using Requip. Iron is critical for dopamine production. Remember before how I said dopamine is low also in this disease? Now think about it. I'm not sure. I'm speculating here. But you notice the substantia nigra is where dopamine is made? And I still need to look up to see, but my guess is that nigra is dark. It's a dark area because it's probably high in iron, because iron is critical for dopamine production. That's my guess. But I think that's going to turn out to be so. Also, there's a study looking at people who had women with fatigue. And they just gave them iron across the board. Now, they gave a really high dose, I think 100, 200 milligrams a day. And they found, and these are women who are not anemic, they found there was about a 25% increase in energy versus placebo. That's quite a bit from just giving iron. But they found that it only helped in women whose ferritins were under 50. That was a cutoff. Over 50, it didn't help. Under 50, their energy came up, which makes 50 a really nice cutoff again. Infertility, 40 is where you see infertility from low iron, with low ferritins.
Any tricks about trying to help people whose iron you're getting, 100, 150, 180, the iron in the blood is there, the ferritin just doesn't. So
Well, if the ferritin's low, that's still one we haven't figured out. But again, you can't really look at the iron percent saturation, because often what happens is they have a chronic inflammation. Their transferrin levels are low. The protein binding it is low. But then the ferritin will go up, or chronic illness. The other way is more explainable. When you have a high ferritin and low percent saturation, that means they're iron deficient, but because of some chronic inflammation, the ferritin acts like a citrate. They can't get it out of the blood, out of the storage into where it needs to be for the iron. The other way around, I still have to go, hell if I know. Now you can speculate low zinc and low vitamin A as one of the factors with that. I will note that zinc deficiency, you can presume to be present in this population, and it is a critical cause of immune dysfunction. I think a very reasonable thing is to tell them to get one bottle of zinc, just so they can get it there wherever it's cheap and easy, 25 milligrams a day, and just take it for 90 days or 100 days till it's gone, in addition to the multis. The multis we usually going to have about 15, which is enough for maintenance. But these patients are zinc deficient because of chronic inflammation. I don't think it's worth our carrying the zinc, because it's just, you're going to be talking about an $8 product for one-time use. I don't think it's worth bothering with. But they just have them go out and get a bottle of zinc.
Bronstein, David Bronstein,
Mhm.
not only checks the zinc, but he also checks the copper level.
Well, Dave's a friend of mine. He's really good. He's focusing on the iodine these days. He's focusing on the salt.
But I mean, would that,
The problem with the copper is that the blood levels are not very reliable. Zinc are really not very reliable either. They give a little better indicator.
he does it on all his patients?
Yeah, he also, I tease Dave. He says, well, you used to do the iodine skin testing and all. And I say, well, Dave, everybody's positive? And he says, yeah. He says, what use is doing a test that's positive on everybody? And he says, well, I don't really do it. Yeah, okay. Okay. So, I think that by the time you're done doing a test that's expensive and unreliable, just have them get a bottle and take it. Copper you don't want to give, because copper is a double-edged sword. If it's low, their SOD won't work, the antioxidant. If it's high, it's oxidative. The vitamin powder just has 0.5 milligram. Now, the way you get the best of both worlds.
The hemopyrrole and cryptopyrrole urinary test through vitamin diagnostics might be useful here.
Yes, now here's an interesting thing. You're saying, are you saying to look for the copper?
For KPU and HPU,
Okay.
it's concomitant with tremendous zinc loss on a daily
Okay.
basis.
Now here's an interesting to look at, because you're going through naturopathy school, and you're getting the same cell of, well, let's see, here's a test that may be useful, costs about $50, $100, may be useful, well, maybe. And if it is positive, say it had 100% sensitivity, picked up everybody who needed it, you would then give them $8 worth of zinc, and you would correct it. Or, presuming the test is not 100% sensitive, and you're missing somebody, all of a sudden now you've charged them $100 to save them 8 that you know is not going to harm them, you know will help them probably. So you can give them $8 worth of zinc and take care of the problem, whether just knowing whether or not the test is reliable or not. I'm teasing a little bit, I'm pushing it to the extreme, but I just wanted to kind of get a sense of how we're trained. Now, why do you think we're trained that way? Who do you think is paying those people to come and lecture about these different tests and the rest? And they are good people. But-
I agree, but the dosing structure is different. You need between 200 and 300 milligrams of zinc per day
Yeah, I think that's dangerous.
to correct that
I think that's dangerous.
short term, and then you taper it off.
I think it's still dangerous. You're going to make them copper deficient for starters, and I know they're going to be checking the coppers too and the whole thing. But if you give 25 to 50 milligrams a day, say you want to go on the higher end, you get the copper that's coming in the multivitamins, so they're covered for the while for doing that. You know you will correct the deficiency. I don't buy it that you have to give 300. By the time you give 300 of zinc, you know why you need that high of a zinc? Because you're so saturating the metallothionein enzymes in the intestine that absorbs the zinc that you can't get any more absorbed unless you kick it so damn high. It becomes a self-defeating cycle. Give them 25 to 50 milligrams a day for 3 months. And you'll correct it. Give them some copper with it so you don't make them copper deficient. It'll cost them $10, $15 if you want to go with a higher dose. No risk. Almost guaranteed to work. Don't have to worry about sensitivity or specificity of the testing. You've got them covered for $15. Or you can do $100 worth of testing, which I think is, if you're doing hundreds of people in the testing, it's kind of like hair analysis. It's good for mass screenings for toxicology, but once you start doing it for individuals, it's pretty unreliable. I think that's where we are with zinc testing. So, forgive me, I'm playing devil's advocate again, because on one side, it's kind of like you have, this pulling on the rope on both sides, and on one side, you have 5,000 people trying to sell you on tests and stuff, and I'm kind of on the other end going, for the patients. So I will exaggerate a bit. But you get a sense of what I'm saying here, with it. And for the iron, again, though, look at the ferritins. If the ferritin's under 50, treat it. The other benefit is they will grow their hair back, at least for the hair thinning. And we have the iron, that's a very good iron, it's 29 milligrams with C. These studies are going 100 to 200, but you're really going to block the absorption with the iron as well. You get a gastritis that decreases absorption. In fact, if you give the iron 5 days a week instead of 7, or 3 weeks a month instead of 4 every day, you get better absorption overall. You want to give iron on an empty stomach, or you lose 85% of the absorption. But we miss iron. It's not exotic. It's not fancy. There's no big market pushing it. Your Equip is about, I'm guessing, $3.50 a pill, and the iron's about 10 cents, 15 cents. So what's you going to hear about? So give the iron, give the iron, give the iron, because that's going to be a critical part of the red blood cell mass. Okay.
I was just wondering, what is our form of iron? It just says chelated. I don't know.
I don't know what it's chelated with, but I'm not so concerned about the form of iron, as long as it'll be on an empty stomach. Beyond that, if it's ferrous sulfate or gluconate or chelate, I like chelates in general. I think they're better absorbed. Usually they can be chelated with amino acids and the rest, but I don't know in this case.
Yeah, the glycinate is the most tolerated by the sensitive patients.
Mm-hmm.
So that's
I'm just wondering.
gentle iron is the brand name of that one for a lot of people.
Good. Yeah, Floradix has it, but it only has like 2-3 milligrams in the Floradix. So if you have one that's a higher, the gentle iron.
There's an everyday dose and there's a treatment dose. Pruvate and the Replevin, those were the 21 days on, 7 days off that you could get through your insurance company most of the time.
Good.
That's
Yeah,
available.
and that's the big push they do, is that they cycle it because that decreases the gastritis and improves absorption.
But that's 325 milligrams opposed to 50.
But that's of the entire molecule, not of the iron itself.
Jacob, I have a completely different view on iron systemically and
Mhm.
ferritin issues.
Mhm.
You see people who have perfectly normal irons with very low ferritins.
Yes.
And these people will not become anemic because if their iron systemically doesn't drop below 9, they
Mhm.
will not become anemic.
Mm-hmm.
That iron is utilized directly in the bone marrow to make the red blood cells. Ferritin is a completely different issue.
Mm-hmm.
Ferritin is the stored iron that has been used for primary response.
Yep.
People who have had multiple infections for a long period of time, you check their ferritin is always low. If they have enough, the levels will be very high and utilized, but
Mhm.
then gradually they deplete
Mhm.
to the point that now they cannot respond to inflammatory indexes.
Mhm.
They're not anemic.
Yep.
Even though their ferritin will be horrendously low, they're not anemic, and
Yep.
their blood iron is still okay.
Yep.
The issue is the relationship is very different, and we're looking at them in a different concept.
Well, what if, because what I propose is anybody whose iron percent saturation is under 22 to 23%, or, not and, or, if the ferritin is under 50. Either way, I'm going to go ahead and treat them.
Oh, absolutely. Ferritin should be treated in any way, and that's not necessarily for
Mhm.
the anemia perception or the
Okay.
fatigue or restless leg,
Yep.
to make them defend against coming infections.
Absolutely.
Because if they don't, they're not going to be able to.
But one of the reasons that iron goes down, the ferritin goes down during infections, is because the body is trying to pull the iron away from the organisms, so the organisms are starved for it. There's this kind of thing that goes with it. But my concept is I'd rather starve. I don't want to starve the patient to starve.
I totally agree with you, but these people will not do well if you give them iron. Because to reach a ferritin level that's therapeutic, you're going to give them 17 years of iron to get there. You
Okay.
have to give them intravenous fertilization. If you don't, they're not going to store rapidly enough.
Yep,
And you'll
you're-
have a problem.
And what you'll find is I'm inclined to give them 3 months, and if they're not moving up, then I'm comfortable giving it the IV.
Oh, absolutely.
And you'll find that Andrea and I usually, where we part paths, it's a very narrow thing that then comes back, and it's just simply 2 ways of getting to the same thing, and that's one of the fun things with it. So yeah, I agree. But the other thing too is A and zinc are critical for iron utilization. You don't want to go too high with the vitamin A because they get birth defects, liver issues, osteoporosis, and they'll come back and deal with you. So 3,500 units of the A, you can give all the beta carotene you want up to 5,000, 10,000. But the zinc is really critical. And again, we forget about it, but I would get 1 bottle and just have them take the 1 bottle to replace deficits, and then what's in the multi will cover them.
Well, yeah, I was wondering, what is the rationale for a completely normal CBC, very good levels of serum iron, but low ferritin and extreme fatigue, which give them a shot of iron, boom, they are absolutely fine. They just feeling excellent. So
Yep.
what is the rationale?
The rationale is that they're iron deficient and that the tests are missing it. Let's take a look. For example, many of us were taught in med school that you do a CBC, and if they're anemic, if their crit's low, then you check an iron and B12, but otherwise they're probably fine, right? Now, what's the sensitivity of anemia for detecting iron deficiency? Is it 90% sensitive? Is it 50%? Is it 10%? 4%. 96% of people with fatigue, with a ferritin under 15, will be not anemic. Their hematocrit will be normal. So a test with 4% sensitivity? But that's what most of us are trained to do. So the bottom line is that if they're low on either of them, we don't know. There's a lot we don't know about the metabolism.
Yeah, that part I don't understand.
But again, I would give them the iron. We have a very good iron product. I think it's excellent. And then, take it away from the thyroid, give it on an empty stomach later in the day, or block thyroid absorption otherwise. So 2 p.m. bedtime. Come the 3-4 month follow-up, their irons just really aren't moving. I think the IV is very reasonable. But be careful with the IM. I would avoid the IM because, again, unless it's proper Z tracking, you will get a tattoo. They will not be happy. So again, iron. Okay, give the zinc with it. What else can we do? One, optimize B12. We want to keep it over 540. And there's problems with getting B12 across membranes. If you look at the spinal fluid levels of B12 in this population, CFS, they're often non-detectable despite normal B12 levels. You got to push it to high levels. I'm comfortable with everybody getting B12 shots. And the patient says, well, my family doctor said it's above normal. It's like abnormal, it's dangerous. It's like saying, that's like saying you have more money in the bank than the other 98% of the population. So does your doctor, by the way, so tell him he needs to empty his bank account until they're in 2 standard deviations. Anyway, you can't, the only way I've ever seen anybody, I haven't seen it, but I've seen anybody could overdose on the B12 is if you fill a bathtub with it and drown them. Okay? I've never seen any other toxicity. And there's many rationales in this disease for achieving super high pharmacologic levels. We have a new B12 sublingual, methylcobalamin, very good for brain function. It's very good in methyl donor and the rest. But get the B12. Give it parenterally, give it orally. Optimize other nutrients, folate, B6, copper, zinc. These are all necessary for blood cell production. Terry? Okay. Okay. Optimize thyroid. One of the symptoms of low thyroid is anemia. And then optimize testosterone. What's a symptom of excess testosterone? What's the main thing you see in men if it goes too high? They get polycythemic. Their hematocrit goes too high.